ethics, and administration. He has been actively contributing to curriculum development, faculty training, and regulatory committees, playing a key role in academic and research advancements. We encourage active participation, so please feel free to engage with our speaker held after the presentation. Without further delay, let us begin this exciting discussion. It is my privilege to introduce our keynote speaker, Dr. Darshan J, who will provide us with deeper insights into this field. Thank you all, and I wish you an insightful and engaging session ahead.
Hello, welcome dear participants and dear colleagues and respected faculties who have joined the today's session. Okay. It's my sincere request to all the participants that please mute yourself and we will discuss, as the title suggests, the overview of the pharmacoepidemiology, its scope, its challenges, and especially from the point of view of a dissertation topic. Okay, so this is one of the publication. Here it shows that you all know that HMG-CoA reductase inhibitors, the statins, the most common adverse effect of the statin is the myopathy, and the dangerous one will be rhabdomyolysis. Of course, it is seen in very few patients, but the risk of the rhabdomyolysis is significantly higher when we combine the statin and the fibrate. Okay, rather than use any single agent for the treatment of hyperlipidemia. This has been published in the American Journal of Cardiology. Okay. Now, we all know that the fluoroquinolones, they are very widely used antimicrobials till date, and they are but through this study, it has been found that peripheral neuropathy is also associated with the use of fluoroquinolones. Sentence. Okay. Now, in these slides, you can see that either we start the metformin or the sulfonylurea as a monotherapy in type 2 diabetes, and if you follow the patients over a 12 months, it has been found that the addition of second agent is more with sulfonylurea as compared to metformin. Now you all may think that why the sir has directly started with all these articles and the crux of these articles. Further to this, you all know that metformin is the gold standard. Metformin is the gold standard for the treatment of type 2 diabetes. But the research and the studies shows that now the metformin has also the role in the pre-diabetes to prevent the pre-diabetic patients to convert into diabetes. So now the guideline has recommended the metformin for the high-risk individuals, obese, who are at the verge of developing diabetes. Discovered for the pain relief, and then in the late 60s, okay, low dose aspirin showed its effect as an antiplatelet agent, and in the late 90s and in the 2000s, it has been found that this aspirin is also useful in prevention of various cancers, especially the colorectal cancer. Okay. Sildenafil, history of approval of sildenafil for the treatment of the erectile dysfunction, you just go through the history. Okay, we all are telling that pharmacology is a very dry subject, but if you just go through the history of the drug evaluation, its indication, its adverse effects, it's very interesting. I'm not going into the detail because of the shortage of the time. But initially, the sildenafil was evaluated for the treatment of the hypertension and angina. But later on, it has been found to be very effective for the erectile dysfunction. Until that, it is the preferred drug for erectile dysfunction. And then the new indication came for the primary pulmonary hypertension. And still it is showing promises. The research is going on for the treatment of the respiratory disorders such as the ventilation, perfusion mismatch, and many more diseases. Okay, and last but not the least, SGLT2 inhibitors. We all know these are the gliflozins, canagliflozin, dapagliflozins. They are approved for the treatment of diabetes in 2013. Okay, and at that time they were not the drug of the choice, but because of its effectiveness in reducing the major adverse cardiac outcome, gradually its role or its status come over and above the other anti-diabetic drugs, and now it goes towards as a parallel to the metformin. Okay, as I told you that the major adverse cardiac outcome were significantly less with gliflozin as compared to other DPP-4 inhibitors. Okay. Now, forget about the all other previous examples. You just focus on the SGLT2 inhibitors. As I told you that they are approved in 2013. Now, it has shown that the cardiovascular adverse effects significantly less, and the adverse cardiac outcome is also less as compared to the other anti-diabetic agents. And you all know that the chances of occurrence of cardiac problems more with the diabetes. Further to this, as these agents, they increases the urinary elimination of the glucose, and that's why theoretically there are chances of urinary tract infection. The n number of the studies conducted to assess and quantify the risk of the UTI, even if it is there. But the thought that the risk is very much high, it is not up to that much. Okay. Various studies, this is one of the examples. Okay. This is another example that the risk of the acute renal failure. Okay, as the SGLT2 inhibitor, they are having somewhat adverse effects on the kidney, but the risk is significantly increased with the use of potential nephrotoxic agents. So one should keep this factor in mind. Okay, and not only with the diuretics and NSAIDs, but the new risk factors with the proton pump inhibitor, anticoagulants found. And it has been also found that the male gender was a significant risk factor. So here I want to tell that you just look at the one drug group, SGLT2 inhibitors. We have discussed about its status as an anti-diabetic agent, its adverse effect profile as far as this urinary tract infection is concerned, its effects in preventing the major adverse cardiac outcome, and there are various other studies in the pipeline. So what I want to convey is that even after the drug is approved, its status, its adverse effect profile, its drug interaction, all this changes through a series of the post-marketing studies. Okay. These we have also previously seen. I have seen you the slides of the aspirin. When the drug is approved, the indication is different, then various other uses found. Okay. So the purpose of showing all these slides is that once the drug is approved for a particular indication, its journey not stops over there. Actually, not only its journey, but the test of the drug in the real clinical environment starts from the point where it enters into the market. Okay. So now we start with, and there is a very important quote that Sir William Osler quoted, that a desire to take the medicine is perhaps the greatest feature which distinguishes man from other animals. Okay. And we are very fortunate that we are having armamentarium of drugs for almost all ailments. And there are newer drugs, biologicals, everything is discovering for the various conditions, which was not there previously. Okay. But importantly, if we are giving the drugs for the treatment of the disease, and even up to 10% of the hospitalization, not only the hospitalization, but prolongation of the hospitalization. And not only it increases the burden of the patient, but on the prescriber side also, from the economic side also, healthcare delivery side also, and many more. Okay. And that's why, as I told you, the drug acts as a double-edged sword. Okay. Now, the question is that we all know that the drug has to pass through rigorous phases of preclinical studies, then clinical trials, and then the drug enter into the market. We all know that the first there are preclinical studies. After that, there is a phase 0 micro dosing studies with very few healthy individuals. Especially we are looking of the pharmacokinetic parameters. Then phase 1 healthy individuals, where we are especially looking the pharmacokinetic safety and tolerability. I'm just going very quickly because our purpose is somewhat else. Phase 2, here we are doing the phase 2 first time in the patients. So we are evaluating the efficacy in the patients and the dose ranging. Obviously, the safety is evaluated at each and every phase. Phase 3 multicentric studies, but few thousand patients. And we are confirming the efficacy and safety that we have observed in the phase 2 trial. And after all that, the drug is going to be approved. And even after that, for that innovative product, one has to submit the post-marketing surveillance data up to at least 3 to 4 years. And the purpose is to confirm and evaluate the effect and safety of the drug in the real life situation. But you just look at the total number of the individuals in all these 4 studies. They are not more than thousands. We are not able to evaluate a very long-term adverse drug reaction or other comorbid condition. The patient is having hepatic and renal insufficiency. The efficacy of the drug in the terminals of the age, pediatrics and geriatrics, and many more. Okay. And that's why there is a need. Now here I want to add something more further, that you just look at the previous slides, that in phase 4 we are looking about the long-term adverse reactions. But even after the phase 4 clinical trials, there are n number of the adverse drug reactions. Even I can prepare at least 10 to 15 slides for it. Okay. out of this, the important is isotretinoin, very commonly used agents in the dermatology, teratogenicity with the isotretinoin. Disproportionate amount of the hypoglycemia. When human insulin was discovered, the disproportionate amount of the hypoglycemia. The drugs that prolongs QT interval and they were banned, terpenadine, estamizole, cisapride, and this intussusception with very commonly used rotavirus vaccine. So what I want to convey is there are n number of the adverse drug reactions. Some of these are serious also. For some of the adverse drug reaction, we have to withdraw the drug also, but that were not found in the even the phase 4 clinical trials. Okay, after the approval of the drug. So obviously the question arises that then how we can rely on the drug? Should we stop using drug, or should we curtail the use of the drug? Should we minimize the use of the drug, or how do we come to know that we should use drug in this condition, in this subset of patients, and in this we should not use the drug along with these drugs, and many more. Okay. So the only solution is observation of real life clinical situation, especially the treatment elements, and generate evidence from the interventional studies in real life situation, and that we are going to discuss in this session. So if I just quickly go back to the learning objectives of today's session is the history and the need of pharmacoepidemiology, the scope, the extent of pharmacoepidemiology. Okay. Different studies included in pharmacoepidemiology and the scope of the pharmacoepidemiology as a dissertation topic. Okay. So this is the solution. Now, so what we should do, or what we have to observe, especially once the drug enter into the market. First and foremost is the effectiveness of the drug in that condition, obviously, but if the patient is having other comorbid conditions, effectiveness of the drug in the extremes of the age, then pattern of the use of the drug. Okay, we all know that if the drug is approved, it is approved for a particular indication, but there are various available uses of the drug. Then if you just look, just presently you do one thing, that for all these PG students, you just go to the ward, or you just attend any OPDs, and you just look the number of the drug prescribed in any particular prescription. You will find that it is not less than 4 to 5. So we have to identify the drug-drug interactions. Then, as I told you, that there are various adverse drug reactions which were not noted in the phase 4 clinical trial. So our aim is to identify the unknown, rare, serious, and long-term adverse drug reaction. And obviously, as I told you, you just look at one of the previous point, that because of the adverse drug reaction, there is a hospitalization, prolongation of the hospitalization. So there is a tremendous economic burden. So again, this is a very different topic, pharmacoeconomics. We will discuss someday somewhere. But whether the treatment is cost effective, cost benefit, or cost utility is there or not. All this is, if you want to know all this, you have to do the pharmacoepidemiological studies. And the ultimate purpose of the pharmacoepidemiology is to make some change in the decision at the level of the policy making, so to maximize the benefit, to minimize the risk to the patient. So all these areas encompasses, this is the scope of the pharmacoepidemiology. So if we just look at the definition of the pharmacoepidemiology, you all know that there is a one branch of the pharmacology, that is a clinical pharmacology. It means the study of the pharmacology in the human beings, and obviously there are two parameters, pharmacokinetics and pharmacodynamics. Okay, so this is the one branch, and there is another branch, that is epidemiology. What is epidemiology? It is the study of the distribution and determinants of health related problems. Okay, now if we use these principles of epidemiology, and if we keep the focus of the inquiry with this PKPD of the drug, then the branch that develops, it is called pharmacoepidemiology. So the focus of the inquiry is of clinical pharmacology, and the method or the principles of the inquiry is of epidemiology. Okay, so pharmacoepidemiology means usage of the principles of the epidemiology to study the use and the effect of drugs. Now whenever I am talking about the effect of the drugs, it includes both beneficial effect as well as the adverse effects in a large population setting and in real conditions. Okay, so this is about the definition of the pharmacoepidemiology. We have already seen the scope of the pharmacoepidemiology. We have already seen what is the need of pharmacoepidemiology. Now, if you just go to the history of the pharmacoepidemiology, it has started as we all know that the use of the drug, as the discovery of the drug significantly raised, the population increases, so the usage of the drugs raises significantly, and in the early 1960s, the drug utilization studies. So the pharmacoepidemiology actually started in the 1960s with the drug utilization studies, and you all know that at the same time period that we have encountered various adverse drug reactions, this thalidomide disaster and many more. So the shift is on identifying the adverse drug reaction. And if you just look at the history, that the first textbook of the adverse drug reactions of the pharmacovigilance published in the 1952 after identifying all these adverse drug reaction. Then for couple of years, this pharmacoepidemiology means this pharmacovigilance. It encompasses many more areas than this pharmacovigilance. Okay. So the primary objective of the pharmacoepidemiology is enhance the understanding. As you are doing the clinical studies in the real life situation in a very scientific manner, you are starting understanding of the various benefits and risks associated with the drug use, and this will help to rationalize the drug use by proper decision making and public health policy. Okay, so which are the potential contributions in the pharmacoepidemiology? First is it is not like that the information that we received from the pre-marketing studies, they are always wrong, but we have to confirm that, we have to supplement that So first is the information which supplements that available from the pre-marketing studies. Okay, and we want to quantify. Suppose the adverse drug reaction observed in the pre-marketing studies, but we want to say, for example, SGLT2 inhibitor, that there is a risk of the UTI, but we want to quantify that risk. Okay, we want to quantify the beneficial effects with the higher precision, and in the patients not studied prior to the marketing, the extremes of the age, pregnant and lactating women. Okay. Then the contribution is, we are going to get new type of information not available from the pre-marketing studies, new indications, prevention of the colorectal cancer with the aspirin. Okay. So new type of the beneficial effects also, and as well as the adverse effects also. Okay, and its implications as far as the economics is concerned. And lastly, that obviously when you keep studying the drug in a real life situation for a long period of the time, you are just doing the checking that whatever the prescribing is there for thousands, I will not use the word thousands, but the lakhs of the people over decades, we have to keep check that are we not doing any harm? Okay, this is our ethical and legal obligations. Okay. So these are all the potential contributions of the pharmacoepidemiology. Okay. Now, which types of the studies included in pharmacoepidemiological studies? You all know that there are two types of the studies: observational studies and interventional studies. In observational, as the name itself suggests, we are just measuring the parameters, we are not doing any intervention. And the started from the case reports, case series, analytical trials, also known as the ecological studies, case control and cohort studies, and the intervention is the gold standard randomized control trials. Okay, but you may find all these in your, as you all know that all the postgraduate students, they have to do the BCBR course, basic course in biomedical research, and there are very nice description and understanding. So we are not going to discuss about this at this juncture. Okay, this pharmacoepidemiological studies, they can also classified in these ways, even if the observational studies are there. But observational studies are of two types in nature. One is the descriptive study, and second is the analytical studies. What is the basic difference between descriptive and analytical studies? You can write in the chat box. Differences between the descriptive and analytical studies. Descriptive studies are there in which there are no controls. There are no controls. Okay. While exactly very good. Control is present in the analytical studies. You are going to analyze. And the classical examples of the descriptive studies, they are the cross-sectional studies, drug utilization studies, ecological studies. Cross-sectional studies are very good to provide a snapshot, the drug use and effects on a population at a particular time. Drug utilization studies, we will discuss this in later. Ecological studies, when you want to know the pattern of the drug use in a specific geographical area or in the particular group of the population, then it is helpful. And the analytical studies, case control, cohort, and the newer is the target trial emulation. But as I told you, we will not go into the detail of this, but we will focus more on the two studies because there is a scope for the thesis topic for the postgraduate students. Okay. One is the drug utilization studies. Okay, why? What is the need of the drug utilization study? Here at this juncture, I want to add one point that previously also you might have discussed with your seniors that n number of the drug utilization studies were conducted as far as the thesis is concerned. Okay, this is very good. Selection of the drug utilization study for a post-graduation thesis topic is a very good, but whenever you are selecting the topic for the dissertation, first thing, always you should keep in your mind that I am investing my 1 to 1.5 year for this dissertation. I am using the resources. Okay, if you are using the patient data also, you are using these resources, investing that your time, your guide time. Okay, is it really worth in terms of supplying the information which can be beneficial directly or indirectly for the improvement of the healthcare system, either as a society level or as an individual level. So why the drug utilization studies? We want to promote the rational use of the drug, maximize the benefit, minimize the harm. But how to do this? How to do this? This can be possible if you are just describing, analyzing, and understanding the pattern of the drug use. You identify which are the population at the risk. Okay, and if you find any particular adverse effect, if you can quantify that adverse effect, you identify the person at the risk. If all this can be done in a scientific way, this is all is drug utilization study. Okay. So which type of the information that can be gathered by this drug utilization studies? Incidence and the prevalence of the drug use, pattern of the drug use, whether the drug is appropriate or not, whether its dosage regime it is appropriate or not, which drugs are used in the combination, whether there is a polypharmacy, whether it is justified or not, switching of the drug, overall expenditure. And a very important area as far as your dissertation topic is concerned, that medication adherence. Which are the factors that are responsible for the non-adherence? Which measures you can take? Okay, dear friends, you can also do the operational research for this. Operational research means that, say, I'm giving you one example. You all know that the tuberculosis elimination program is going on. Government is providing the highly valuable free of cost drugs to each and every patient of the TB. And in this program, if you just do a research on this execution of the program, that yes, if I can make this much change, if the treatment adherence is concerned, if the follow-up is concerned, and if you just look at the outcome of your intervention, that is called the operational research. Okay. With the drug utilization studies, you can also come to know that whether the drug is misused or the drug is overused, or the distribution is on one way of the totally prescribed or dispensed drug. All these information can be gathered by drug utilization studies. Okay. Now, at this juncture, the important thing is to identify and certain terminologies in the drug utilization studies. Okay. These commonly used terms, AT and DT. How many of you know that what is the need of, just let me know that what is the need of this ATC and DDT. You can write in the chat box. Okay. You know that the ATC, it is a code to classify the drugs according to the anatomical, therapeutical and chemical properties. Okay. Anyone? What is the need of this ATC classification? Drug is also already classified. What is the need of this classification? Because whenever you want to compare the data across the population, across the different regions of the country at the national level, you must have some standardized nomenclature. Then and then you can compare. And the same way, defined daily dose. What is the defined daily dose? It is the average assumed maintenance dose per day for drugs used for its main indication in the adults. If you just look at the antimicrobial, say for example, the amoxicillin, the DDD is 5 gram. It means that, and it is per 1000 bed. Okay, so 5 gram amoxicillin per patient used daily in a 1000-bedded hospital. So when you want to compare the consumption between the different institute, between the different setup, between the different healthcare delivery system, between the different countries, you must have some defined criteria for that. That's why these two. You all know about the incidence. So the rate of the new users over time calculated by dividing the number of the new drug users by the percent time at risk, prevalence, proportion of the existing users calculated by dividing the number of the current users, both new and old, by the total population count. For this, we are having two types of the studies. One very commonly used studies. Nowadays, you all know about the antimicrobial stewardship program. Okay, its importance. One of the very important but still very feasible study is the point prevalence study. Okay, you can just do a one study that, okay, today you just collect the data of all the outpatient department patients attended their prescription. Okay, and the antimicrobials usage. You can do the point prevalence study. At the same time, you can also do the period prevalence studies. Okay, then prescribed daily dose. Okay, here one thing always remain clear: those students who are going to do the drug utilization study and especially the focus on the DDD, that prescribed daily dose is the drug amount to be taken daily according to the dosing instruction. And while the DDT is somewhat different, so PDD is always bound to be different from DDD. Okay, adherence. Again, I am emphasizing this point that many studies are required. There is a scope that we are not having the data that why treatment adherence is not there. There are n number of the factors. There are social factors, there are patient-related factors, there are drug-related factors, there are factors related to the geography, there are factors related to the prescribers. And whenever you are executing any policy, whether really it is executed, it is implemented, that is also very important. And so implementation means the extent to which the patient actual dosing corresponds to the prescribed daily dose. Whether the prescribed daily dose is really taken by the patient, that is called the implementation. And this is again a very important area where you can select your thesis topic. the prescribing quality indicators. Okay, it is a measurable element of prescribing performance. Again, I am repeating, it is a measurable element of prescribing performance for which there is evidence or consensus that it can be used to assess quality and hence in changing the quality of care provided. This is very important. So now I'm going to discuss something more about this prescribing quality indicators. There are n number of the indicators, but they are classified into or categorized into certain subheadings. There are certain drug oriented indicators like the drug dosage, whether the selection of the drug is appropriate or not, the route is appropriate or not, dose is appropriate or not, frequency is appropriate or not. There are certain disease oriented factors and there are certain patient oriented factors. Okay. Now the indicators for the WHO, World Health Organization, they have given the indicators, different set of the indicators. Now these indicators are different for evaluation of the different parameters. For the OPD patients it is different, IPD it is different. These are some of the few examples that the mean number of the drugs per encounter. This is one of the indicators. Percentage of the encounters with their injection prescribed. Percentage of encounters resulting in the prescription with antibiotic. So the purpose is you can measure the prescribing behavior objectively and these indicators can also be used for comparison of the prescribing pattern. Okay, you can identify the behavior, you can find out that this behavior goes in some other direction, then you can compare the behavior. All this can be done. Okay. Now, what is the contribution of the drug utilization studies? If you can understand by heart the potentiality of the drug utilization studies, then I am pretty sure that you can definitely take this topic as a dissertation in a more scientific and appropriate way to assess the appropriate use of the drug, to identify why there is a variation in the drug use between the different populations, which are the factors. Okay, you can also, as I told you, that you can also develop quality indicators. You can use the quality indicators. Say for example, I have forgotten the name, but the quality indicators tool is available for the chronic disease, which is a 22 different set of questions. And again I am focusing on the important point is measuring the treatment persistence. What is the treatment persistence? Treatment persistence means it is a measurement from the time from the initiation of the treatment until it is discontinuation, and the reverse is the non-persistence. So you can measure, you can quantify the treatment persistence rate, you can find out the reasons, you can do some innovation, some intervention, and then you measure the persistence. Okay, and the last point of this is the article published in 2001. As I have told you that nowadays the corona, we can tell that if we can compare the COVID epidemic with the antimicrobial resistance, we can say that COVID epidemic is just the tip of the iceberg, and the name of that iceberg is antimicrobial resistance. And dear friends, this is the article published in 2001 in which it has been shown that screen sharing. Sorry. Am I audible? You just write in the chat box. Okay. I think that the duration is of 1 hour only, so we are sharing the second link once this meeting is over. Okay, wait for that. My screen is visible. Continue. Screen share है. Okay. Continue. Okay. Okay. Then here in this, that there is a need of pharmacoepidemiological studies to understand the antimicrobial usage, to understand the resistant pattern. So there are and studies needed to integrate microbiology, pharmacology, and epidemiology. Okay, we have to require a data which links between the bacterial resistance and antibiotic use. There is a need for the research to determine the best strategies for the optimal use of antibiotics and to estimate the effect of antibiotic exposure on the risk of emerging resistance as well as on the dynamics of the diffusion in the population. Okay, so here in my last part, I want to tell you something more about the pharmacoepidemiology and antimicrobial stewardship. Okay, so for this antimicrobial stewardship, pharmacoepidemiology is a scientific approach. We all know that the more the antimicrobials are used, more will be the resistance. But we require a scientific approach to analyze, to quantify, to evaluate this problem in the population and its consequences. Okay. So for that, what we have to do, as I have told you in my just previous sentence, that more the exposure of the antimicrobial, more will be the development of the resistance. So first and foremost, we have to monitor. We have to just observe what is going on. So we have to monitor the use of the antimicrobial in the hospital and the community settings. All the sentences that I am telling now onwards, they can be a full dissertation topic itself, and it can be a part of the dissertation topic. Okay. Then identification of the determinant factors. Why these particular antimicrobials are utilized? As I have told you, the DDD. If you find that the DDD of amoxicillin is more in this setup as compared to another setup, what are the reasons behind it? We have to identify the socio-cultural determinants for the variation in the antibiotic consumption. Okay, once we monitor or once we do the observing or if we do the prescription analysis, we come to know that the points for the irrational prescribing. What are the reasons behind it? There are n number of the studies. If you just look in the PubMed that there are many reasons, and the two most important reason is, one is the patient pressure, okay, and the second is the unawareness or unawareness from the prescriber side, because there are n number of the studies which have shown that the inappropriate use of antimicrobials is different at the different healthcare level. At the PHC it is more, at the CHC it is somewhat less, at the tertiary care center it is even more less. You may find the different result also, but then you have to dig out the reasons for that. For that, what you have to do? You have to interview with the prescribers and the patients. When you interview with the prescribers, you come to know that there are a number of the reasons. Okay. But for that, you have to first monitor the use in the hospital and the community settings. Now, why the patients? Patient pressure, it is one of the another reason. So you have to first you have to know the what is the belief, what is the knowledge of the patient, what is the attitude of the patient, what is the belief of the patients, and not only the patients, but their caregivers. Okay. Then the another thing is, you can also select this topic that whether the prescription of the antimicrobials are actually there according to the local resistance pattern, according to the antibiogram. What is the use of the broad spectrum antibiotics? What is the use of the particular antibiotics? Can you compare the use of the broad spectrum versus narrow spectrum? What is the use of the antimicrobials in the ambulatory setup, in the emergency setup? What is the use of the antimicrobial? What is the prescribing pattern as an empirical therapy? I have already told you the prescribing patterns at the different level of the healthcare. And unfortunately in our country, the antimicrobials can directly be available without the prescription as a OTC medication. So you have to identify the number of the antimicrobials, which antimicrobials, for which indication. You have to communicate with the pharmacy stores. Okay, you can make an interview with that also. And the most dreaded complication of this antimicrobial resistance is that you all know that now the development of the hospital acquired infection, it is increasing, and the pathogens that are identified that are not susceptible to any of the available antimicrobials, and we have seen the n number of the deaths in the ICU of our near and dear ones also. But the causal relationship between the bacterial resistance and the mortality, we have to identify in the scientific way. Okay. So all these are the possible topics for, this is just the one area of the antimicrobial stewardship. Okay. And lastly, that if you have made some change in the policy or the treatment guideline, does it has any impact on your local antimicrobial resistant pattern? Okay, so ultimately you have to do something which is having some direct or indirect help to the society in terms of the improvement in the patient outcome. Okay, there is a one separate session can be arranged on the pharmacoepidemiology for the antimicrobial stewardship. So here I conclude this session. We have discussed about the need of the pharmacoepidemiology, different terminologies. Before leaving, we are releasing the link for the feedback. Okay, you just submit that link. Okay, so we come to know that what are your perceptions, what you want in the future. So please fill up that link which is shared in the description. Okay, in the chat box it is there. Fine. Now one more thing I want to emphasize is that I want to thank Dr. Arvind Panwar sir for giving me this platform to make a talk on this pharmacoepidemiology, and you are free to ask any questions on my personal email ID, which is there in my first slide. Can you just show me the first slide quickly? Okay, you can ask the questions on this. Okay, now hand over to Dr. Vishwa.
Thank you, sir, for the insightful webinar. It was highly informative and engaging. Looking forward to applying these learnings in practice and participating in future sessions. So now we have some time to take questions. You can write your questions and queries in the chat box. Sir will get back to it. And also please fill the feedback form. We have given the feedback form in the chat box and also sent a link in the mail. We will try to get as many as possible. So please start giving your questions.
Yes, there is a one question that how to incorporate. What is that question? Dr. Vishwa, you just read it out.
Yes, sir. How to incorporate pharmacoeconomics in pharmacoepidemiology study.
Okay. Now, for that, you have to look out that what is the pharmacoeconomics. Obviously, we are looking at the economic analysis of the drug usage for a particular condition. Now, there are different studies. Actually, you don't have to incorporate. Pharmacoeconomic study itself is a pharmacoepidemiological study, as I already told you. But which type of the study you can do? You can do the cost benefit studies, okay, cost effective studies. Now, what is the difference between these two? That cost benefit study means that the money that you are using for the treatment of a particular disease, whether there is any benefit in terms of the reduction in the hospital stay, the improvement of that condition, that is called the cost benefit study. Then cost effective study, you can also do the cost effective study that you are using the drug you are using a particular drug, you are doing some economic expense, whether that is effective in terms of the relief or the cure of the disease. And then the cost utility study. Cost utility study, it means that you must have heard about the term quality adjusted life here. Is there any improvement in the quality of the patient? So this type of the studies you can do. This is known as the pharmacoeconomic studies, and this is actually pharmacoepidemiological studies. So all these are the studies. That's what I want to convey. The pharmacovigilance, all the ADR studies that you are doing, that is a pharmacoepidemiological study. All the drug-drug interaction studies you are doing, that is pharmacoepidemiological study. All the safety and the effectiveness you are studying is also a pharmacoepidemiological study. Pharmacoeconomics, that is a pharmacoepidemiological study. If you are studying a particular drug in a particular age group, that is also a pharmacoepidemiological study. Okay, but just start doing the studies, because if you just look at it, if you read any article and in that article, if you just focus on if there is a pharmacoeconomic part, unfortunately we are not having the data of our own country. So start doing pharmacoeconomic studies. You just start first with the cost effectiveness study. That is first. That is the easiest one. Then you can do the cost benefit studies, and then you will go for the cost utility studies. There are various indicators, parameters available for the quality adjusted life years. Okay, one more question regarding the Dr. Vishnu. Yes.
Is drug utilization for antibiotics similar to therapeutic audit using WHO indicators for antibiotics?
Can you show this question on the chat box? I am not getting you. Can you repeat that?
Yes, sir. Is drug utilization for antibiotics similar to therapeutic audit using WHO indicators for antibiotics?
Yes. Up to certain extent, it is true. Up to certain extent, but uh, WHO has given the specific indicators for the antimicrobial consumption also. That is one. There are certain additional indicators also available for the identify the rationality of the use of the antimicrobials. If you are interested, you can mail me. I will provide you the possible references. Okay,
Okay, sir.
but just one thing, that prescription audit is just a one subset of drug utilization study. It is a one part of drug utilization study.
Okay, sir. We have another one. Can we use electronic health records to evaluate ADR in pharmacoepidemiology studies?
Definitely, very good question, and yes, you have to and have to use. Okay, you have to take the permission. Okay, uh, if, if you are using, I don't know, the question has been asked by which students, but if you are having a DR monitoring center, you can use your own data. That is one thing. There is no doubt about that. You have to just acknowledge the PVPI. If you want to use the national level data, you have to ask for the permission of the PVPI. Actually, the usage of the data that is available at the national level for any particular program, it is one of the best source for gathering the data for pharmacoepidemiological study. Very good. Very good. Any other, Dr. Vishwa?
No, sir. There are no other questions.
Okay.
Participants can write questions if there are any.
Okay. So, thank you very much. We will meet again in the future with some other topic. Hope you all have filled the feedback form. Hand over to Dr. Vishwa.
Okay, that's all. Thank you, everyone. Now, I would just say that it was highly informative and engaging session, and we surely look forward to apply all these things in practice in real life. And we will participate in future sessions. So, everybody, please fill up the feedback form. We conclude here. Thank you.